Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome back Dr. Mark Edney. You are the Medical Director of the Surgery Service Line at Peninsula Regional Medical Center, and you're here to talk about a very important topic that's getting lots of press of late, and I think a lot of people just don't understand it as well, is antibiotic resistance. So thanks for coming in to discuss this, and let's get started. What exactly does that mean, antibiotic resistance?
So bacterial infections are caused by bacteria, which are single cellular organisms. They're live organisms, billions of which live in our bodies normally. But there are varieties that, if they're in the wrong place in our body, can start to cause disease. They cause inflammation and infection. So that's what a bacterial infection is a bacteria inciting the body's immune response to create inflammation and disease. And so that you can get infections in almost every different organ of your body. And so bacteria, and over the years, we've learned, starting really with penicillin back in the 40s, we learned through experimentation that there are chemicals that suppress and destroy bacteria. And so those are the whole field of antimicrobials or antibiotics that we've been using over the years. And we have a graphic to show that almost as soon as antibiotics get introduced, resistance to antibiotics develops very quickly. And what resistance is there are certain bacteria, because they're living organisms, when you hit a population with a poison, there are usually a few of them that learn to live even though you have that poison around, and they flourish. So the bacteria that are susceptible die, and they leave behind the ones that are able to live in that environment. And that's just how organisms, any living organism, thrives, is they have adaptations that are suitable to their environment and are successful enough to put off poisons and survive, and that's what happens. So these bacteria live, and that's the development of bacterial resistance, and it's done at the gene level. Bacteria possess genes which they can actually share with each other, so bacteria that are close to each other can share the key to resistance of antibiotics, and thus it goes. And not only in human beings, but throughout every animal on Earth. These bacteria are learning how to live in rougher and rougher environments and responding and surviving through every antibiotic we throw at them. The problem is that we've seen this antibiotic resistance come to fruition in our hospitals and in our communities. We're finding bacteria that are resistant to every antibiotic we have available. And it's estimated that in the United States there are upwards of 200,000 or 300,000 illnesses and hospitalizations annually from antibiotic-resistant bacteria, and anywhere from 20,000 to 40,000 deaths per year. And we're just seeing the tip of the iceberg right now. Those numbers are going to start to get worse. And so this is a huge call to action for lots of, this is a complicated issue, and it's going to, the solution to it's going to be complicated. So what you're seeing now is, as the public conscience is becoming more attuned to this, is there are lots of different roles to play with respect to preventing this.
Sure.
From the healthcare community, and providers of healthcare have to be very attuned to this. Healthcare consumers, patients, people bringing their children into the pediatrician for care, bringing themselves to primary care offices, to emergency care clinics, and to others with what they think to be infections. There are lots of issues that they need to be aware of, and we'll also eventually talk about the food industry also has a role to play in slowing down this growing threat of resistant bacteria.
Sure, and before we get to that, because I think it's very intriguing, the various sources of the problem, let's talk about that timeline again, because you mentioned resistance develops quickly. I mean, how quick is that? Could you give us some examples of antibiotics that have come along and how some have maybe been effective for this many years, and then others, resistance develops very quickly?
Sure, and it's all over the place. There are some, if you look back in the 1960s when levofloxacin came on the market, I think in 1966, almost immediately there was a bacteria resistant to levofloxacin. Others have enjoyed a longer period of time of very high susceptibility before resistance has crept in. So it's really all over the board, anywhere from as little as a few weeks or months to 10 or 20 or more years. But we see it develop. It's an ongoing process, and it's a matter of time. It's usually not, it's a matter of when and not if, that resistance will develop. And so we really need to change our awareness of this and change some behavior patterns and the way we approach healthcare and lots of these other other areas.
So is the time period that antibiotics are staying relevant decreasing, you're saying? Because when penicillin was developed, wasn't that used for quite some time? And now we're in an era where a few weeks, months, years, you're saying?
It can be, and it's different for different bacteria and for different antibiotics, so it's a little all over the place. There was actually some fairly quick resistance to penicillin when it was first developed, so even it, as the original antibiotic, didn't enjoy a really big time frame of huge susceptibility. Resistance developed pretty quickly, so it is a bit all over the board, but it's an ongoing process that's going to continue.
Well, I know there's been a lot of news about all this in terms of people getting certain infections that, you know, they're trying all kinds of different antibiotics and nothing's working. So it can have a devastating impact both to that person and, of course, you're saying the numbers are growing dramatically.
Absolutely. And so a couple of the more common conditions that people present for and are treated inappropriately for, and when I say inappropriate treatment, very well-meaning healthcare providers are trying to do what they think is right, but ultimately are giving antibiotics for conditions that don't require antibiotics. And there's plenty of blame to go around. Patients are demanding antibiotics. I mean, I see it in my office with quote-unquote urinary tract infections. Some women do get real urinary tract infections, but I get all kinds of referrals to my office for urinary tract infections that aren't UTIs. Every single symptom of a urinary tract infection can potentially be explained from a non-infection as well as it can be explained from an infection. So people come into the healthcare environment, whether you're bringing your child to the pediatrician or you're bringing yourself to the primary care doctor, the urologist doctor, or to the ENT or to the emergency room with what you think to be a urinary tract infection. The other big one is upper respiratory tract infections. We're coming up on flu season. The colds, the sniffles, the stuffy head, the feeling lousy. Some people say, oh, I've got this head cold. If I could just get a Z-Pack, I could make it all go away. The truth is the vast majority of upper respiratory infections are viral. And antibiotics don't work for viruses. And that's really a key point, is that and what happens is the patient will come in and say, oh, I've got this head cold, I just want a Z-Pack, give me my antibiotics and I'll get out of your way. The busy practitioner says, great, here you go, here's your antibiotics. Both people are happy. The patient went in for something, they asked for something, they got it. The provider feels good because they've done something for the patient. Everybody leaves happy. And in fact, in 4 or 5 or 6 days, the condition's going to go away anyway. These viral upper respiratory tract infections go away on their own and they take several days. And people make the erroneous assumption, well, it must have been those great antibiotics that made my condition go away. It wasn't. It was going to go away on its own. What in fact just happened is that you've put yourself at higher risk of creating resistance in your body, but your body's bacteria, for a condition you didn't need antibiotics for. And so we just need some awareness. And again, we're not pointing the finger at any one party. Everybody needs increased awareness, from providers of healthcare to consumers of healthcare and people who are presenting to providers for these sorts of problems, because everybody has a role to play in being very specific about what infection are we treating. If we're calling this a urinary tract infection or an upper respiratory tract infection, are we testing, are we getting a sample to test to see if there are bacteria there, and are we using the appropriate antibiotic for the appropriate duration and in the appropriate dose? There are even caveats to that. We can talk about the notion of bacterial colonization in the bladder, and this is something I see a lot, especially in people as they get older, women more than men, but as women get older, this notion of colonization becomes very, very common. What colonization is that bacteria normally live in the bladder. And so you can actually do a urine culture on an older woman and grow bacteria, and they may be having no symptoms at all. That's being called UTI and being treated with course after course after course of antibiotic. I see these referrals for these women who have come to me for quote-unquote recurrent urinary tract infections. And my first question to them usually is, what symptoms are you having? And half of the time, the answer is, I haven't had any symptoms, okay? That's not a urinary tract infection, and those antibiotics are being used inappropriately. And not only is it a wash, it's harmful, okay? We're doing the society and our healthcare, our community, a huge detriment by putting this pressure of antibiotics in there, and we're really helping these bacteria become resistant and create the problem that's being created.
Well, the antibiotics have side effects, and particularly in vulnerable populations, when you mention older adults, kids, or for any person, I imagine, not to mention the cost of an unnecessary medication being used. and then of course the impact. I wanted to get back to, you mentioned, I think in pediatrics there's a really strong pressure on physicians, with mothers coming in with sick kids and they feel like they have to do something.
Sure, absolutely. So yeah, you put in, the very protective instincts of mom, and their baby's not feeling well. They've got the sniffles, they've got a fever. I mean, fevers in the pediatric population are incredibly common. Some of them are from infection, a lot of them aren't. But the assumption is, oh, my baby's got an infection, I'm going to go into the pediatrician and get some antibiotics. And they go in with that on their agenda. Number one is leave the pediatrician office with some antibiotics. And pediatricians are busy people and they're kind people, and they want to please families and do well. And that the inclination is to just write the antibiotic and let's everybody move on with our day. And the baby gets the antibiotics and gets better. They were probably going to get better anyway, but we've again, in some cases, inappropriately prescribed an antibiotic that again, not only has not done anything for the child, but has actually caused harm by promoting resistant bacteria. And we've got to have that on our radar screen, is that antibiotics are not benign interventions. Okay, most of them have very few side effects, but we're not talking about the side effect of the pill. We're talking about the effect of the pill on the bacteria and the creating of resistance, which is causing an enormous problem. And that's where the awareness needs to come in.
Yeah, that's a far greater problem. But they also
Absolutely.
have side effects. I think a
Sure.
lot of people just feel like, oh, medicines are benign, and they're
That's right.
not.
Yeah, you're absolutely
even
right.
in the general sense. So, we mentioned the prescriber and feeling pressured. Is part of it the fact that many physicians just don't have time to do teaching or education, to take that extra few minutes to explain to people? I mean, I know physicians are very pressured to see a lot of patients in today's managed care world.
There's an enormous amount of pressure to get through the day and to be very focused and efficient on identifying the problem, coming up with a solution, and moving on to the next. You're exactly right. And the onus really is on physicians and physician extenders, the PA and nurse practitioners who are seeing these patients.
Because they ultimately write the prescription, right?
They write the prescription as well as do the physicians. And so yes, there's a huge education piece that we are responsible for, that we have to take that extra few seconds to do. And we're going to spend about a half an hour talking about this issue, and I wish I had in half an hour to describe all of the complexity of this issue to my patients. That's why it's great when you do these shows, because it gives us time to really dig into these issues. And it's really, all of this information is important to provide context for patients so they understand what should be treated with an antibiotic, and to stick up for themselves and say, if I need an antibiotic, I want it. I do not want an antibiotic if I can avoid it, for all of these reasons. So absolutely, the education piece is critical for those of us who are writing antibiotic prescriptions.
And on the patient end, I know you mentioned sometimes people feel like they need to leave the doctor's office with some kind of prescription. The other thing is, I know I teach the students about bladder infections and those kind of issues, where we know people sometimes will get a prescription for antibiotics and not take the entire prescription. They kind of take half and put some away for next time, and that's another abuse of the system. And I know maybe that doesn't go on as much as it used to, but
yeah, no, it happens, and that's another sort of it's a responsibility of a patient to take them as prescribed for the duration that they were prescribed, and not sort of stockpile them for a rainy day. A lot of people like to have a little stash, and that's another sort of problem from a common behavior in the patient population in the community. Is people will have their own stash of antibiotics at home, and I'll hear this story. Women will come in and say, "Well, I had an infection a month ago, but I just had some antibiotic on the shelf, so I just treated it myself." That's an extremely dangerous thing. Yes, there are women who do have true recurrent urinary tract infections and do know when they have them. So there is that population of people. I'm not saying that people can't sort of self-diagnose from time to time, but there's a huge risk of misinterpreting, again, some symptoms that can either be indicative of a urinary tract infection, the frequency that can come with it, the burning with urination, the bladder pain. All of those things can be there as a result of something else other than infection. So this whole notion of self-diagnosing is, oh, I'm peeing frequently, it must be a UTI, I'm going to take these antibiotics I have on the shelf, is potentially a very dangerous assumption to make. And so I really discourage people from stockpiling their own antibiotics and self-diagnosing and self-treating, because ultimately they are very potentially contributing to this problem.
In themselves as well, correct? Next
Absolutely.
time around, it might be difficult to find the medicine that works.
That's right.
And you also wanted to touch on the fact that there is some blame to go around to the animal food industry. Explain that.
Absolutely. When you look at pound for pound antibiotic usage sort of in our country, actually the vast majority of antibiotics are used in the animal food industry and growing livestock for the food supply. And so we're talking about poultry, beef, pork. Antibiotics used for a variety of different reasons in the animal industry, and a couple of them are legitimate. There are high-risk populations, or when outbreaks of certain types of diseases occur in these animal populations, you've got to treat certain populations of animals to protect them, and to protect herds and those sorts of things. But antibiotics are also used just to promote growth of the animal, to create bigger, fatter, more robust animals that yield more meat. That's the area in the animal industry. We really need to stop using antibiotics as a matter of course just to promote growth. They should be used in a specialized situation to either treat infection or prevent infections. But that's an enormous use of antibiotics. And again, these same bacteria shift back and forth between the animal world and the human world. So any resistance that starts to develop in animals, either through lots of different routes of communication, and that gets complicated, but through food processing, and you hear a bit of salmonella outbreaks or E. coli outbreaks in the food chain. So I think vegetables that get contaminated. We wash vegetables with water that's been on a farm. That the chains of conduction of these bacteria get very complicated, but they're out there, and some of them develop in the animal industry, and so there is responsibility for producers of animals for food to very responsibly use antibiotics and not use them when they don't have to. And our own Purdue right here on the lower shore has been at the forefront in the poultry industry of getting antibiotics out of the food chain. And so they're certainly to be applauded. And there are a lot of other producers of protein, again, the beef, pork, and other chicken producers ought to follow their lead and as much as possible reduce antibiotic use.
Well, that's good to know.
Yeah,
I like
absolutely.
to support Purdue.
Absolutely.
Now, I know you said this is a problem across the country, and also here you had a little biogram, you call it, that actually gives some examples of which antibiotics are being used around here in certain situations and which ones are developing a higher resistance.
Absolutely. This is from PRMC. This is called an antibiogram. This is produced on an annual basis. And what this does is it tracks each of the different types of bacteria that have been grown in culture from various specimens, whether it's sputum or urine or blood cultures, different types of bacteria, and across the top is listed all the different antibiotics that we have available to use. And it gives you a number with respect to what percentage of these bacteria are still sensitive to that particular antibiotic. For example, this is an inpatient card. I deal a lot in urology with E. coli. It's a very common urinary tract bacteria.
Now that's normal flora in the bowel.
It's normal flora in the bowel. When it gets into your urinary tract, it can cause problems. And so for our E. coli on the inpatient side, you look at all the isolates of E. coli, there's a 62, you probably can't see it on TV, but there's a 62 in this box with respect to Cipro, meaning 62% of the E. coli is sensitive, meaning 38% of the E. coli in the inpatient side is resistant to ciprofloxacin, a very common antibiotic used for E. coli. So we are starting behind the curve. That 62 is getting lower, meaning more and more resistance is developing, and it's in large part the inappropriate use of ciprofloxacin in the community.
Now, what would a physician do? Would they not use Cipro in that case,
So
knowing that, or do they
probably
try it?
You'd probably use an alternative antibiotic. A lot of that would depend on individual patient factors. How sick is the patient? Do they have sepsis, which is a body-wide infection, or do they have an infection limited to sort of one area of their body? All of those things would factor into whether you would try Cipro first, or do you need to back up to a broader antibiotic to make sure you get it. Really depends how sick the patient is.
I guess you're trying to make the best educated guess possible.
Absolutely.
Based on the circumstances and
That's
how
right.
sick the patient is. It sounds very complicated.
It is. It is.
So, again, in this situation, how many alternatives are available to a physician in many of these cases?
Right. So the number of different antibiotics that may be applied really depend on the type of bacteria that you think might be the causing agent at that point. And that's going to be different based on whether we're dealing with a bladder infection or an ear infection or a throat infection. But over time, as resistance develops, it used to be that 20 years ago, we could just say, well, we have a couple other higher power antibiotics that are about to come out. We can just wait and we'll have a new gun that we're able to use. That pipeline is all but drying up. And that's another concern. We're really getting to a perfect storm with this problem, is that resistance is getting worse. These bacteria are getting more and more virulent. That is the ability to make people sicker and sicker. And the pipeline from the drug companies is drying up. It costs hundreds and hundreds of millions of dollars to develop a new antibiotic, to test it, and a great deal of time, upwards of 10 years, to go through testing to bring it to market. And so it's an enormous time and expense to develop these. And a lot of these companies have said that we just don't, as a company, we can't survive if we keep dumping all of this money into these types of drugs. And so, again, companies are focusing on sort of cardiovascular drugs and all sorts of other newer drugs to, in lots of different systems. And the antibiotic pipeline is really starting to run dry. So we're running into a problem. We desperately need newer drugs to treat the newer infections from these resistant bacteria. And we're finding ourselves in a situation where we're having fewer and fewer alternatives to go to. It just lends pressure to the notion that we really need to educate ourselves on this topic and start thinking about bacteria and start thinking about antibiotics in a different way, in a much more responsible way.
So even under the best of circumstances, you're saying for these drug companies, the return on investment, they're afraid to move forward in this area because, as you mentioned earlier, in a few weeks, months, or a year or two, that drug they developed and spent all that money on may no longer be effective and used.
That's right.
Okay, so what are we to do from an educational standpoint? It sounds like, everyone needs to take responsibility, including physicians, educating patients, and then patients being educated and understanding. So what do you suggest, or how do we move forward with this?
Yeah, absolutely. It's all of the above. And I would say from a patient perspective, if you are going into your healthcare provider because you believe yourself to have an infection, stop short of going in with that agenda of, I've got to leave an antibiotic. I'm just going in to get some antibiotics and get on my way. I want patients to start having a healthy skepticism for the use of antibiotics and see them as dangerous drugs. They are potentially helpful in certain circumstances, but if they're used inappropriately, they are potentially very dangerous drugs. And we really need to start thinking about antibiotics that way. They're not just a free ride, and it's not just a matter of, well, if I take this course of antibiotics and I don't get better, it's a wash. It's not a wash. It's a net negative, because you potentially are producing these resistant organisms that can come back and cause huge problems down the road. So I want patients to have a healthy skepticism for the notion of infection and what is and isn't infection. If you're having a set of symptoms, you may have a fever, you may have all the signs of a potential infection, but listen to what your healthcare provider has to say and discuss. Do you think this is an infection? Do you think I need antibiotics? Rather than going in with the agenda, I want the antibiotics and I won't be happy unless I leave this appointment with antibiotics, have a healthy skepticism about it. From a provider standpoint, we have to have the same level of skepticism, because again, we as providers are as guilty as a group of people of overprescribing. It's estimated that up to 50% of antibiotic prescriptions in the United States are inappropriate, either used when no antibiotic is required, or written the wrong type of antibiotic, wrong dose, wrong duration. Okay, so we don't do very good as a provider community at being specific and targeted with our antibiotic prescriptions. The onus is on us to get better educated about, again, being certain, using guidelines to determine what is a urinary tract infection. A dipstick positive urine with a little bit of blood does not equal infection. And I can count, I would need more than 2 hands to count the number of times I see people referred for recurrent UTIs when no culture has been done. They've had a dip positive urine and usually minimal symptoms, and have been treated with round after round after round of antibiotics. So the onus is on us as providers and as primary care providers and emergency room urgent care providers to understand current guidelines for diagnosis of things like urinary tract infection, upper respiratory tract infection, and what is responsible use of antibiotics and what isn't. So everybody's got a job to do, and that's ours. And I think, in the food industry, again, I think it's the responsibility of corporations to be responsible stewards of antibiotics in animal husbandry. We desperately need and require food source and protein sources. It can be done responsibly with the appropriate use of antibiotics without overutilizing them and contributing to the problem. So everybody's got a job to do.
And I guess I hate to think about scare tactics, but I think people need to think about down the road what it means that one day you could get an infection and we're going to run out of medicines that work, that can treat, and we don't have many in the pipeline, if at all. So it is kind of scary if that person is you and there's no medicine to treat that bacterial infection you have. because of all the misuse in the past. I guess that's making it, oversimplifying it, but I think it's true in part.
Sure, and that's a real feeling of desperation when you know what's causing the problem, but you are defenseless to do anything about it. And we're going to start seeing that more and more as these resistant bacteria cause bigger and bigger disease.
And I imagine physicians are very concerned about this.
Extremely
if they
concerned.
get in that position. So.
Absolutely.
So a lot of education to go around, which is why we're here at Focus on Health.
Yes.
So I'd like to thank you for being on the program and bringing this issue to the forefront, where it belongs, it sounds, for a good bit of time. We really need to focus our energies on education and proper prescribing.
Absolutely. Thanks for having me.
And thank you for joining us for this edition of Focus on Health here on PAC 14.